Hello everyone, I'm Dr. Elliot Arseniadis with the Save the Bottoms Community Outreach and Research Enterprise focus on anal cancer awareness, screening, and prevention at the University of Minnesota. Today we'll be talking about anal cancer screening. What is it and who should be screened? This video is for any provider, either future or current, who is interested in screening their patient population for anal cancer. So first off, we'll discuss who is at risk for anal cancer. What do we mean by screening? And then finally, who should be screened? So who's at risk for anal cancer? Well, overall, it's a relatively uncommon cancer, about 1.7 per 100,000 person years in the United States. But some groups are at especially high risk. The quintessential high-risk population that we have studied the most are men who have sex with men and transgender women who are living with HIV. And so this population can have risk up to 100 per 100,000 person years. Now, per 100,000 person years is kind of this nebulous term that even I don't really understand. So to put it somewhat into context, I'll point out that colorectal cancer, the third most common cancer in the United States, has a risk of 50 per 100,000 person years. And this is something we screen for quite intensely. Cervical cancer, when we first started screening women many decades ago, had an incidence of about 30 to 40 per 100,000 person years. And thanks to screening, it is now only about 7 to 8 per 100,000 person years. And so we can see in this extreme high-risk population, over 100 per 100,000 person years is pretty high and pretty risky. Those living with HIV who are not MSMs or trans women also have a high risk. So both men and women living with HIV who are not otherwise MSMs or trans women have about a 30 to 40 risk per 100,000 person years. Similarly, men who have sex with men and trans women who are not living with HIV also have an elevated risk, and that can be up to about 30 per 100,000 patient years, especially as they age to 60 years or above. Women with prior gynecologic cancers or precancers are also at high risk. And this is a really important population because this is an extremely large population. There are many women who've had a prior remote history of gynecologic dysplasia, either of the cervix, the vulva, or the vagina. Interestingly, of the over 10,000 new cases of anal cancer diagnosed in 2024, over 7,000, so well over 70%, were in women, and the vast majority of these had no other risk factor save for a remote history of gynecologic dysplasia in the remote past. I want to especially point out that women with vulvar dysplasia or cancers are at extremely high risk, with risk up to about 40 to 50 per 100,000 patient years. And so for all of those budding OB-GYN or current gynecologists or gynecologic oncologists, I want you to be really cognizant of your patients who present with vulvar HPV-related disease because they are at extremely high risk for anal dysplasia and anal cancer. The immunosuppressed are another high-risk patient population, especially those who have undergone solid organ transplantation. Men 10 years out from solid organ transplantation can have up to 25 per 100,000 risk, and women 10 years out can have a risk of up to 50 per 100,000 patient years. So again, a very niche but important population to be screening. So when we say screening, what do we actually mean? In general, when we talk about anal cancer screening, what we're really talking about is anal dysplasia screening because we really don't want to find cancer. At that point, the cat's out of the bag and we have to treat any invasive anal cancer, whether it's stage 1, 2, or 3, with chemotherapy and radiation, which can have lifelong effects on urinary, fecal, and sexual function. So what we really want to find is anal dysplasia, anal pre-malignancies that we can see and treat through a procedure called high-resolution anoscopy. We know that this works and can help prevent the progression from high-grade dysplasia to anal cancer from the ANCHOR trial, and we'll discuss more about the ANCHOR trial and the details in a separate video. So when we screen for anal cancer, what we're really screening for is dysplasia that we can find and treat, just how we screen for colon cancer by looking for polyps and removing them before they turn into an invasive cancer, or breast cancer where we perform mammography to find DCIS before it progresses to invasive cancer. Same thing here. We want to find it in that pre-malignant state where we can still treat it locally and prevent it from becoming an invasive cancer that we have to treat with chemotherapy and radiation. Just a reminder, screening is always for asymptomatic patients. If you have a patient come in with anal rectal complaints like bleeding, pain, or mass falling out of their anus, they are no longer asymptomatic. They are symptomatic and warrant a full investigation and examination of the anal rectal region, and then referral if something untoward is found. In asymptomatic patients, we can do screening, and that's traditionally described in two separate methods. One is the digital anal rectal exam, and the other is the anal swab, or the unfortunate name of anal pap smear, which has developed over the course of years. Now, a digital anal rectal examination is for patients where there is no access to high-resolution anoscopy. It usually can only find larger high-grade lesions or, unfortunately, early invasive anal cancers. The gold standard would be the anal swab or the anal pap smear. And there are two components to this traditionally. The first looks at cytology, so it looks for abnormalities in the cells, and those are graded along the same continuum that cervical cancer cytology is done. Then there's also HPV testing. Now, these results may come back differently based on what your laboratory does. At the very least, they should be saying whether or not high-risk HPV types are present. They may further go on to perform HPV genotyping, where they may say if certain high-risk types like 16 and 18 are present, and then they may further delineate other high-risk HPV types or not. But at the very least, you should be finding out whether high-risk types are present or not, and then genotyping if available. So who should be screened? For the remainder of the talk, we'll be talking about the International Anal Neoplasia Society's 2024 Consensus Guidelines. Interestingly, that same year, the NIH, CDC, and HIV Medical Association of the Infectious Disease Society of America together promoted these guidelines as well, but specifically in patients who are living with HIV, since this was a working group specifically focused on those patients. And so this past year in 2024, we have these doubly endorsed guidelines that I'll share with you today. Now, they're separated into two categories. Category A, where risk is greater than 17 per 100,000 patient years, and Category B, where risk is less than 17 per 100,000 patient years. And this is based on the general risk of 1.7. So anyone with 10 times or greater the risk was categorized in Category A, and those with less than that but still greater than the general population went into Category B. And so, first and foremost, at the top of this list, we have our MSMs and trans women living with HIV, where screening with the anal swab, preferably for cytology and HPV testing, begins at age 35. For those men and women who are not MSM or trans, living with HIV, screening should begin at age 45. And then for MSMs and trans women not living with HIV, similarly, screening should begin at age 45. For women with a prior history of vulvar dysplasia or cancer, screening should begin relatively quickly, either at the time or within 1 year of diagnosis. For those who have undergone solid organ transplantation in the past, screening should begin at about 10 years post-transplant. And this is really our category A patient populations. Especially don't want to miss the MSMs and trans women living with HIV. Don't miss those. Start screening them at age 35, the rest at age 45, and for those with vulvar disease, within a year of diagnosis, solid organ transplants within 10 years of transplantation. Some other patient populations exist in risk category B, and really we need to know more about these populations before providing strong guidance. But in general, shared decision-making for these populations can begin at age 45, again with anal cytology and HPV testing. For those women who've undergone cervical or vaginal cancer or high-grade dysplasia in the past, people with a history of perianal warts or persistent cervical HPV-16, or for those who are immunosuppressed for reasons other than having received a solid organ transplant. Again, more to come in the coming years on these patient populations, especially those women with prior cervical and vaginal dysplasia. I want to thank you again for participating today. Hopefully we will see you soon on one of our other videos. In the meantime, please visit our website at savethebottoms.umn.edu and visit on Instagram, Threads, X, and YouTube, all our social media presence at Save the Bottoms. Thanks again. See you soon. Bye now.